So as Len says, thank you for inviting me to come once again to this meeting. And there were about 15, 20 questions that I was given in advance, which I hope I will cover. And then there should be time at the end for any additional questions. So I looked at those questions and I grouped them approximately into four. So what is the PSA? Why is it used? When should we use it? And what are the guidelines for its use? And can we do better? So it's all in the name, prostate-specific antigen. And it's a protein and enzyme which is secreted by prostate cells. And its normal physiological role is to help liquefy semen. And so in the seminiferous vesicles which sit on top of the prostate, where the semen is manufactured, the level of PSA is way higher than in the prostate. And it's important to understand, as I think you all know, that the PSA is produced from both benign and malignant sources. And as a rule of thumb, you get more prostate PSA from cancer than you do from benign prostate cells. So roughly 10 times as much. Now, as we get older, the prostate gland enlarges due to benign prostatic hypertrophy, and that will increase the PSA level. So as you age, the PSA goes up. So what do we use the PSA test for? Well, there are several areas that it could be used for, and I just want to start with some definitions. So screening, in the medical sense, is very carefully defined as a defined population, for example, men between the ages of 50 and 75, who have no symptoms of the disease. And the aim of screening is to detect cancers at a stage where treatment is either more successful or perhaps associated with less side effects. But it's a population-based program, and that differs from when it is used for diagnosis. So if I am getting up at night 3 times, or I have blood in my urine and I go to see my family doctor and give him those symptoms, the family doc may well request a PSA test. And that is not screening, that's testing. And there is a controversy about PSA screening, which I'll touch on in a moment, but there's no controversy at all in its use for diagnosis. And then we can use it also for monitoring people who are on surveillance or watchful waiting, or who have had treatment, and we can use it as a surrogate for the success of the treatment. This is one of the questions. Why should I get a PSA test? Well, I'm going to rephrase that, because why might I get a PSA test? I think is a more appropriate way of putting it for many people, although there certainly are occasions when you should get it. So a PSA test might lead to a diagnosis before it otherwise would have turned up. And as I've mentioned, it might lead to better outcomes. You should get a PSA test as part of the workup of a suspected prostate problem or in monitoring treatments. So for screening, if you are at higher risk of prostate cancer, then you may be more attracted by screening. So if you have a family history, for example, and you should be reasonably healthy with about a 10-year life expectancy, because the PSA detects cancers typically many years before there are any other signs. And even an untreated prostate cancer rarely causes significant problems within 5 years. So that's roughly where the 10 years comes from. And if you're going to go down the screening path, you have to accept the potential risks as well as the potential benefits. And people say, what do you mean risks? It's a blood test. Well, the risks are of a false positive result and the anxiety that might result from that. And the majority of men diagnosed with PSA screening have a very low risk cancer, and about half of them don't actually need treatment, but actually about 3/4 of them end up having treatment. So there are people who get unnecessary treatment. And because treatments have side effects, if it's unnecessary treatment, there'd be no benefit and you'd be left with the side effects. So those are the risks. And generally, I think it is accepted that a population-based screening program, the risks outweigh the population benefits. Now, that might not apply to an individual within that population, but the concept of screening is on a population. Now, diagnosis, as I've mentioned, to investigate symptoms or an abnormal digital rectal examination, and it's largely independent of life expectancy, because if you're very elderly and you're going to die in a year's time from something else, but if you have a lot of prostate problems, then it could well be that we can make you feel better by treating the prostate problems. So in terms of diagnosis, the benefits outweigh the risks. And in my world, because I only see people who come to me with a diagnosis of prostate cancer, this is where PSA for me is most useful. It's in monitoring response to treatment, the early detection of recurrence, and it helps guide which is going to be the most appropriate treatment for the person in front of me. So when might you start getting a PSA test? Well, if you're going to go do screening, you want to screen initially at an age when prostate becomes a risk. And that prostate cancer is very unusual under the age of 50. I mean, I have seen a handful of patients in their late 40s, and I think I saw one person who was 41, but that's in a 30-year career. Maybe you want to start screening a bit younger if there is a strong family history. And when do you want to stop PSA screening? Well, when you're at an age where other conditions make an early diagnosis of prostate cancer unlikely to influence your quality or quantity of life, which is where the 10-year thing comes in. So as you get older, and particularly if you have important other medical conditions, then the value of a PSA falls below everything else, like your blood pressure control and your diabetic control and everything else that you're discussing with your family doc. Now, one of the questions, can PSA test detect prostate cancer? Well, it sure can, but it also detects benign enlargement and both infective prostatitis and non-infective prostatitis. And the PSA can also be affected by recent ejaculation, by bike riding, and a rectal examination. So if you are given a PSA requisition by your family doctor and he's just done a DRE, then you probably want to wait 3 days, which is the half-life of the PSA in the bloodstream, and also avoid the other things. Now, they don't always affect the PSA level, but you don't want to get a false positive from the test. And this graph illustrates the problem quite well. This is from a series of several hundred men who either had prostate cancer or did not have prostate cancer. So the controls without prostate cancer are the dark bars, and the open bars are those who have prostate cancer. And the scale is logarithmic. And you can see that there's as much overlap as there is either side. And so if you have a PSA here of about 4, you're just as likely to have prostate cancer as not. And even at a PSA level of 20, although yes, it's much more likely you do have prostate cancer, you could still have some other condition. And contrary-wise, you can have a PSA level less than 1 and still have prostate cancer. So PSA, unfortunately, is not a great test. It's often called the best marker in oncology, but really that is for people who already have a diagnosis of prostate cancer. Now, last time I addressed the group, and some of you may have been present, I showed this curve, and I just want to go over it again because it actually is to me, very helpful. It's called a receiver operating characteristic curve, and it's a way of graphically displaying the balance of sensitivity and specificity, which determines a good test. So here in the top right-hand corner, we have a level of 1. This is a PSA level of 1. If we chose this as the threshold for a test, what this tells us is that it's a very sensitive test, but it's not at all specific. This is 1 minus the specificity. So what that means is everybody with prostate cancer, 95%, are going to have a PSA level of at least 1. But unfortunately, you're going to pick up a ton of people who don't have prostate cancer. So that would be a useless test. And contrary-wise, down in the bottom left-hand corner, if we chose a threshold of 20, it would be very specific, because almost everybody with a PSA of 20 will have prostate cancer, but it wouldn't be sensitive at all, because only a minority of men have a PSA that high, even with prostate cancer. And this dotted line is like tossing a coin. And the area under the curve of tossing a coin is 50% of the total, which is why it's 50-50. So if we chose a PSA level here, 5, 6, 7, which is, we actually go more down here, but you can look at the area under the PSA curve is 67%. In other words, it gets the right answer 2/3 of the time, and the wrong answer 1/3 of the time. And frankly, that's not good enough. If you're going to do PSA screening in a mass population, you can get a third of false positives. And all the anxiety and biopsies and side effects and infections and bleeding and everything as a downstream of just having a biopsy. So we need to do better. So one of the questions again asked was, what about new tests or refinements of PSA? So the first two which are bolded there are refinements of PSA. So the PSA density corrects for the prostate size. You simply take the PSA level and divide it by the size of the prostate. Now, most of us don't know the size of our prostate, but a urologist or a radiation oncologist can examine you and get an estimate from a rectal examination. Better would be to have an ultrasound, but you don't want to start doing ultrasounds on everybody. But this can be very helpful, for example, in the active surveillance situation where we already have a diagnosis and a prostate volume. So if you had a PSA of 7.5 and a 50 cubic centimeter prostate, you do 7.5 divided by 50 is 0.15. And the lower the better, but less than 0.1 is good. And above 0.2 indicates probably a higher burden of prostate cancer within the prostate. And then free PSA. So it's a bit complicated, but PSA normally is bound to a protein called alpha-1 antichymotrypsin. And curiously, prostate cancer produced PSA is more tightly bound, and so there's less of it that is unbound or free. And so if you look at the ratio of free to bound PSA in somebody without prostate cancer, it's typically 30, 35%. But in somebody with prostate cancer, it's much lower. And one of the thresholds that can be used is less than 15%. We don't often do the free PSA because nowadays it's recognized that if you have an age-adjusted elevated PSA, that by itself is probably an indication to proceed and see a urologist, etc. Now, PCA3, Pro-PSA, and HK2 have all been studied mostly in those with prostate cancer who have been through a prostatectomy where they have tissue, which is required for one of these tests rather than being a blood test. And it can help with the prognosis, but it is not good at diagnosis. And I've summarized this to say that none of these have yet been shown to significantly improve the overall accuracy of prostate cancer detection. Now, the Pro-PSA and, I can't remember which one it is, maybe it's PCA3, do increase the area under the curve from that 67% we saw with PSA up to like 72%, 75%, but it's not a game changer, unfortunately. Now I'm seeing the chat. I'm just going to open the chat. Yeah, we're talking about post-treatment. Let's come on to that because I'm actually going to address that question a bit later. Just for your interest, this is out of date, 2003. I'm not aware of more recent data from Canada or BC, but basically over half of the age group that's relevant, which is over the age of 50, have had a PSA test at some point. And for many of these, it was a few years ago. But many of them, it's actually quite recent, within the last year or two. And of course, this is mixing together PSA testing for symptoms, PSA monitoring for those who are known to have prostate cancer, along with screening. So it doesn't actually tell us the amount of PSA screening that goes on in Canada, but we know anecdotally a lot of family physicians and a lot of patients have had it done. I'm not going to get sidetracked too much into screening because it's a topic we could talk about all day. But just to summarize, there are really only two proper studies that have addressed the utility of PSA screening. There are lots of poor studies that I'm not going to talk about, but in Europe, they did a large study. It's had a lot of follow-up now, 20 years follow-up. And what it showed is that if you have every 2 or 3 years a PSA test and you have action with an abnormal result, there is a 30% reduction in your chance of developing metastases and a 30% chance of less of you dying of prostate cancer. But there are controversies within this. There was actually a collection of little studies in different countries with different criteria. And the positive results were seen more in Scandinavia, and the negative results in France, Spain, and Italy. And there's a theory that the Mediterranean diet and sun exposure may decrease the risk of prostate cancer, as opposed to, the darkness and also the Scandinavian genes, which confer a particularly aggressive type of prostate cancer. In the UK, there's a fantastic study. It didn't actually randomly allocate patients to screening. It randomly allocated family practices, family doctor practices, to be a screening practice or a non-screening practice. So in the screening group, patients were told about the PSA test, would they like to have it done? And about half of them said sure and had a PSA test. In the non-screening practices, they just did standard affair. They had like a leaflet lying around in the doctor's office about PSA testing, but it was never brought up by the family physician. And with probably not sufficient follow-up yet, there is still no difference in the chance of these people dying of prostate cancer. The shaded bits are the confidence intervals around these figures, and there's an overlap. But I would predict in 5 years' time, there will be a difference. And it's very similar to what we've seen in Europe. So I think we do have evidence that there is a modest benefit if you live to be 20 years after you have a PSA test. Now, over my career, the incidence of prostate cancer has gone up and down with the introduction of PSA screening and testing in the late 1980s, General Schwarzkopf promoting PSA screening after he was diagnosed with prostate cancer. I think there was a federal minister who got prostate cancer, and that led to a little increase. But generally, in the last decade, the use of PSA testing has decreased. And there's been a decrease in deaths. And I'm going to blow up that death chart so you can see it a little bit more clearly on a different scale. Now, this is age-adjusted prostate mortality. So it takes into account the aging population and the changing demographics of British Columbia, or Canada in this case. And there's been a substantial decline in prostate cancer deaths over the last 25 years. Now, we collaborated with Ruth Etzioni, who works in Seattle, and she's done some very clever modeling using the individual patient data from the screening trials. And the estimate is that improvements in death rates are 1/3 due to improvements in treatment and 2/3 due to screening. So this black line is the death rate observed, which, as you see, is nicely defined. And without any treatment at all, it would have gone up. Or with treatment, the estimate, as I said, is 1/3. So here, it's not proof, but it's very suggestive that there is a benefit in terms of prostate cancer death rate. So here's a question I was asked: at what level does a PSA test suggest that I might have cancer? Well, this is not well understood by physicians or by the laboratories, but we've got a really great study where they took volunteers between the ages of 55 and 65 who had who had a normal rectal examination, and these men agreed to have biopsies. And they then looked back at what was the biopsy positivity rate according to the PSA level. And so even with a PSA level of 1, there's a 10% risk. PSA level of 3, 24%. Very high figures, much higher than we'd ever suspected. Fortunately, if you just look at high-grade cancer, it's much less than that. So a PSA level of 3, for example, in its age range that I described around the age of 60, only 5% will have a high-grade cancer compared to 24% who have prostate cancer on a biopsy. And as I think you may have read, if we took a 60-year-old man and took out his prostate gland, we'd find there's a 50% chance of microscopic prostate cancer because this is such a common occurrence as we age. In terms of screening, BC Cancer has had this out for over 10 years, but I still think it stands the test of time. We recommend that men without symptoms, because of course we're talking about screening, 50 years or older, who are expected to live at least 10 years, who are well informed about the risks of overdiagnosis and overtreatment, they consider having PSA testing. But we do not recommend there should be widespread population-based PSA screening because of the potential for overdiagnosis and overtreatment and consequent decreased quality of life. So this is what the family physician knows. And if you are 50 and you see a family doc, and I don't know why you'd be seeing them, but say it's blood pressure check or something, then you should ask the family doc, hey doc, do you think I should have a PSA test? And get their input. And if it turns out that you've got diabetes, you've had 2 heart attacks, you've got uncontrolled hypertension, the answer probably should be no, let's deal with the more important things first. Now, this is what I recommend. It's what I've done for myself, and it's what I teach students. So you get a baseline test at an age where the chance of having prostate cancer is very, very low. And it's been shown from some great studies in Scandinavia that they had archived blood samples that had been deep frozen, and they used their cancer registry 30, 40 years later to look back at what was the PSA level at the age of 45 for this man who was diagnosed at 70 with prostate cancer. And the probability of prostate cancer is shown in the graph with confidence intervals around it, but it's really dramatic. So in your late 40s, if you have a PSA level of 1, you have 20% chance of being diagnosed clinically with prostate cancer. In other words, having symptoms. And if your PSA at that young age is greater than 3, you have a 60% chance of growing into problems with prostate cancer. Another way of looking at that is advanced prostate cancer. These are people who may die of prostate cancer. So again, if you have a PSA level of over 1 at the age of between 45 and 50, you are 7 times more likely to have a lethal prostate cancer than a man who has a PSA less than 0.5. And the risk goes up substantially. So the problem is not many family physicians know this, and the normal ranges on the lab reports don't reflect this. They still talk about PSA level less than 2.5 in a man under the age of 60, I believe. And that's wrong. If I had had a PSA of 1 at the age of 45, well, I would have checked it, of course. But I've gone and phoned Larry Goldenberg and said, hey, Larry, my PSA is 1 and I'm only 46. What am I going to do about it? And I would expect that he would have done an MR scan and maybe a biopsy. There is a problem with this approach, though, and that is this. You have to take it really seriously, and you have to tell a man at the age of 45, avoid ejaculation, avoid bike riding, and if you have urinary symptoms suggestive of an infection, please don't have the test now. Wait until it's all settled down, because a false positive at this age could be devastating in terms of insurance cover and anxiety and a roller coaster of biopsies, etc. So my view of PSA screening, is my personal view, is that a screening program, population-based, likely does more harm than good. But it should be offered with the provisos we've discussed. And if the guy wants to have it done, then he should have it done. Do it at the age of 45, repeat it a year later, the result should be under 1. And then you can tweak the frequency of screening according to the results. So if the result is less than 0.5, just do it when you're 50, when you're 60, and finally when you're 75. And in parenthesis, you have the results that I'd be happy with at those ages. If it's 0.5 to 1, then do it every 4 years. And if it's over 1, do it annually and be prepared to see a urologist. So there's a question, are there any studies that compare PSA increases and having prostate cancer? Yes, there are. Actually, many urologists will use not the absolute level, but the change in level. And I can't remember what the threshold is. It's something like 0.27 in a year. But that is used as an adjunct to the absolute level. But there's a danger here that I see in my practice. There's a bit of bargaining that goes on between the patient and the family doctor. So the PSA level, let's say it's 3. And the doctor says, well, we should repeat it in 6 months. And it comes back as 2.9. And then they say, oh, well, it's gone down a bit. Let's do it in a year. And then in a year, it's 3.2. And then they say, well, we probably don't need to check it that often. And a few years goes by, and then it's 7. And the problem is, if you're going to do PSA screening, you have to be prepared to act on an abnormal result. And I did an audit of my last 100 patients a few years ago, and 90% of the people, in my view, had had delays, like the one I've described with bargaining, or an abnormal result, which was clearly abnormal, which had been filed away and nobody had looked at it. And so it's actually a minority who follow through with PSA screening in a proper fashion. Now, if the randomized studies showed a relatively small benefit and the study was done properly with the right interval, with the right action, including referral to a urologist for a result over 2.5 in Europe, for example, if it was done properly and there was a small benefit, we believe that if it's not done properly, there's likely to be no benefit. Anyway, so this is what my view is. And you should be prepared to go and see a urologist if you have PSAs at those thresholds. And you should stop. The previous slides were over 80-year-olds, over 50% had had a PSA test, and some enormous number, like 25%, had had one in the last year. That surprises me because not many 80-year-olds actually are going to benefit from PSA screening. This was incidentally, I was part of this consensus statement, and some of this detail is in that paper. Now, PSA, moving on, helps us detect, identify what's likely to be the right treatment, and we do that by risk grouping. And in my world of non-metastatic prostate cancer, I use this every day. I group men into 3 groups: low risk, intermediate, and high risk, based upon the stage of the cancer, the grade of the cancer, and the PSA level. It's also, of course, used for what we call extreme risk, where it's a very high PSA or high grade, or locally advanced, where there's a bulky tumor present, and where it has spread to lymph nodes, bone, or elsewhere. It's also a predictor of outcome. It's not as accurate as the grade. That is the most important of the prognostic factors, the Gleason grade, or the group grade as it's now called. And it is better than the digital rectal examination, which is really subjective, even in expert hands. So this is where PSA in my world is really useful. It's in assessing treatment response. The easiest is surgery. If you have successful surgery, within about a month, any PSA that's residing in your bloodstream will disappear, and you should have an undetectable PSA. I'm going to show a few graphs like this. On the x-axis, we have time, and on the y-axis, we have a logarithmic scale of PSA. The surgical definition of relapse is a rising PSA breaching a level of 0.2. This is a patient of mine with brachytherapy. I'll talk about a little bounce that occurred in a moment. And you can see it took a few years for the PSA level to get really low. And at last follow-up, it was barely detectable. The prostate is still present, so there will often be a small amount of PSA. And our definition of a relapse after radiation, whether it's external beam or brachytherapy, is a rising PSA greater than 2. So 10 times higher than after surgery, simply because the prostate is still in place. This is very scary if you're a patient, and it used to cause me anxiety. This is actually somebody I worked with, not a physician, but somebody I worked with at the cancer clinic that I treated. And at the time of treatment, he was pretty young. And his PSA went down initially, and it went up, and then it went up. Well, PSA bounces are commoner in young men. And I knew from looking at the dosimetric assessment of his prostate implant that I'd done a good job. So I reassured him that this was a bounce. But I was actually anxious because to get a bounce up to whatever this is, 8, is unusual. But it came down with no treatment. And actually met him a few months ago, and it's very low. I don't have the result graphed because I'm no longer looking after him personally, but he's cured. The main thing about a bounce is to take professional advice and don't get overly anxious. And whatever you do, don't let somebody give you hormone therapy because they think this is a relapse when it turns out to be a bounce. That would be the worst thing to do, because then you'd be on long-term androgen deprivation therapy with all its potential side effects. So we add this. Sorry?
Prostate.
I didn't get that. Okay, I'll move on. So it's basically, you shouldn't have a subsequent fall in the PSA. Sorry, you should have a subsequent fall. This is what we don't want to see. This is somebody, the PSA is definitely going up. It's going up faster and faster. The numbers here, the 8 years, the 1.5 years, the 0.9 years refers to the PSA doubling time. On a logarithmic plot, you can see that this is not a straight line. The PSA is going up quicker and quicker and quicker. And this man, whose name I don't know who he was one of my patients, unfortunately had metastatic prostate cancer. And having a relapse after treatment, whether it's surgery or radiation, is not a good thing. This graph shows the chance of dying of prostate cancer without a PSA relapse. I think there was one person, because it's pretty unusual, maybe 2 people, pretty unusual not to have a PSA relapse and die of prostate cancer. Those who have a rising PSA are at risk of dying of prostate cancer. And in this era, in the 1990s, it was roughly 30% after 7 years after detection, after you hit that threshold of 2. Now, I haven't updated this because I don't have the data to do it, but we know there's been fantastic advances in the management of prostate cancer, even advanced metastatic prostate cancer. And so the outlook is very much better than it used to be when I generated this data. We can use PSA for research. Here is a study that I did comparing the outcomes of men who were matched for stage and PSA, etc. They were treated either with brachytherapy or external radiation. This is like night and day. After 8 years, the brachytherapy cure rate was 95%, and it was 75%. I'm sorry, after 5 years, it was 95% with brachy, 75% with external beam. And this curve continues to fall off quite markedly. I still use external beam radiation in those who cannot or should not receive brachytherapy. We can look back at the advances that have occurred. So we can correct for PSA level, grade, and all sorts of other things, and look by era. Again, I would like to be able to update this, but the big database that we established in the 1990s, we didn't continue it after about 10 years because it was too onerous to do so. But you can see that there was definite improvement in the job that we were doing. This was with external radiation in this study. I mentioned PSA doubling time. It's actually quite important. If your PSA goes up fast, you're going to do worse than if it goes up slowly. I think that's very logical. And I have a spreadsheet that I have about 50 patients in where I add the PSA results as I get them, and it automatically calculates the PSA doubling time. This guy is 27 months, and then it was 7 months, and then it's slowed to 17 months. And you can see the trend line is definitely up, but the results do wiggle around a bit. And you should expect this because PSA is a biological test, or rather test with PSA is biological, and it is more susceptible to lab and day-to-day variability than a chemical test is. So the PSA doubling time, whether you have surgery or radiation, can predict outcome. And the top two curves are one with radiation and one with surgery. For those who have a rising PSA, where the PSA is going up slower than doubling every 3 months. If the PSA is going up faster than doubling every 3 months, whether you have surgery or radiation, unfortunately, it's the same. In this study, after 6 years, 50% of people have succumbed to prostate cancer. So although having a PSA relapse is important, because it means there is growing cancer, it also brings on anxiety quite naturally. But the patient is probably completely asymptomatic. And there's this very long lead time we get from PSA testing of about 6 years before there are any physical signs or symptoms of prostate cancer. And so if you jump too early with treatment, the patient may not benefit and may be harmed from the side effects. And there have been studies, which we don't have time to talk about today, which basically suggest that you should select out those men who need treatment, which are the ones with high-grade cancers originally and fast increasing PSAs. They're the ones who need treatment now, whereas all the other people with slowly rising PSAs who maybe have other comorbidities, they may not need treatment at all. And I have patients whose PSA I've watched go up to over 100. Bone scans negative, CT scans negative, no symptoms. So that's rare. Usually we intervene much lower levels, but I have had people do very well for a long, long time. Another question. The PSA test gives you false or negative readings. Is there another way of checking? Well, yeah. I mean, we only got PSA in 1980. Before that, what did we do? We examined the patient, both the rectal examination, abdominal examination, for lymph nodes. We did bone scans and CT scans. We did what's called lymphangiography. They inject dye into the lymph vessels, which are between the toes, really unbelievably, and it's taken up by the lymph vessels and tracks up through the body, and it can show enlarged lymph glands missed by a CT scan. There's also blood tests. Alkaline phosphatase is mainly produced by the liver, but it also can come from bone. And acid phosphatase is more specific to bone. And if you have a man with bone metastases from any cancer, actually, but particularly prostate cancer because of the way it irritates the bone, these two blood tests can be elevated. And then there's about 5%, I've seen figures of 10% as well, of men who have a significant disconnect between the amount of their tumor that they have and the PSA level. So you just have to be aware of this. I mean, it's not common to diagnose prostate cancer under the age with a PSA less than 1, but there are going to be a few percent. We saw it on one of the graphs earlier. And you just have to remember, if you're the patient or the person looking after that patient, that this guy doesn't produce PSA. And you have to use other markers, such as the scans that I've referred to. PSMA PET scan is one of the new players on the block, very, very good at detecting prostate cancer, which may have recurred or at diagnosis. You can get false negatives and false positives are pretty unusual. You can get false negatives of PSMA PET scans, but not correlated, as far as I'm aware, with that 5% who have a disconnect with their PSA, because it's not looking at PSA. It's looking at prostate-specific membrane antigen, which is on the surface of the cancer cells, which is different from this enzyme. Okay, almost finished. A couple of other questions. Are immature white blood cells related to PSA level? I'm not aware of that. I quickly Googled it and drew a blank, so I don't think there is a definite connection. And then, can you donate a kidney? Well, you can't donate a kidney if you've had a malignant disease, which I think is what this is referring to. So if you didn't have cancer and you'd had radiation for, I don't know, a benign condition, which we rarely do, or you'd had your gallbladder removed, yeah, you could donate a kidney then, but not if you've had prostate cancer. I don't really know how evidence-based it is, but the issue is that transplant recipients are immunosuppressed. And there have been cases, not in prostate cancer, of people using the donor kidney, and the donor didn't know they had a malignant disease, and then the recipient can develop that cancer. So that's why there's an absolute no to that.